Hello everyone, good morning, good afternoon.
Good afternoon.
Feels like a different time zone, but we actually, I'm from the Philippines and we have the same time zone, so maybe that's just me being nervous. Hi. So in order, I want to be respectful of everyone's time, so I'll try, we'll start on time so that we'll also end on time. So thank you everyone for being here. My name is on the screen, Carmina Charmaine Domingo. I go by Ina. Ina, that's my nickname. I'm the clinical program manager at Elizon from Cebu, Philippines. So today, I am going to discuss a topic that is often very challenging, but important to discuss: suicide. And in this particular case, we're going to talk about suicide prevention and intervention among human trafficking survivors. I want to acknowledge that the topic that we are discussing today is deeply sensitive, and it may bring up challenging emotions or memories for some of you. And so it's very important to take care of yourself throughout this session. Hi, hello, hello. And so if at any point you feel the need to step away or to seek support, please feel free to do so. You may reach out to me after the session, but I'm sure the ARAT team has also been very kind, so you don't have to process anything alone. So what am I going to talk about today? So of course, we're going to talk about suicide. Sorry, I keep looking at my back, but then I have my screen here. My apologies. So we're going to talk about what is suicide, particularly what is the suicide spectrum. Why is it important to talk about suicide? So in this case, for clients, by clients we mean the survivors, service providers, and in general for the anti-trafficking community. And then, towards the end, I'm going to share with you about the suicide prevention and intervention methods that has worked for us at the Liaison in the Philippines. Hopefully, for this to be a learning experience from everyone, hopefully you can pick up something from my presentation, but also towards the end, maybe I can learn from you as well. Maybe you can share some of the things that has worked for you, for your clients, for your organizations, and maybe we can combine our minds and look into, or see how we can support one another in our productive work. Okay, so, I moved back. Okay, there you go. So before we dive into the core content of my presentation, I'd like to hear from you first. So I'd like to ask, what brings you here today? Do you have a microphone? You have a microphone? Chad, you please help me out. Okay, thank you so much. Okay, I'd like to ask maybe a few hands from the audience, 1, 2, or 3, to just share. There are no right or wrong answers. Just curious. Yes, hi.
Hello. I can be really loud.
Okay.
Hello. I am here because I run a vocational program in Cambodia, and I work with a very broad background of young people coming out of trauma. And I have many young people that are self-harmers, and I myself have a background in trauma and also self-harm and constantly kind of dealing with my own struggles. Being a leader of young people also dealing with trauma, I can become very triggered. I can definitely fall back into suicide ideation, and I want for myself to remind myself too, like what to do when I am not feeling my best, so that I can provide the best support for my team.
Awesome. Sorry, I didn't catch your name?
Oh, Amber.
Amber, thank you so much, Amber. So it's a personal reason, but also as part of the work and wanting to share the message and support the stakeholders of your organization. Awesome, thank you. I saw another hand. Yes, please. Hello, everyone. To those who just arrived.
Hello, this is Rajeshri Denoy from Mahima, India. So I am here today because we are running shelter homes for the traffic survivors. So, as we know, when a child has gone through so many traumatic experiences like sexual exploitation, child labor, everything, and when the trust is completely broken and all the self-blaming is prevalent in the child, the suicidal ideation is very, very common, because that time the child feels that, okay, ending my life is the best way to come out from this pain. So how we can prevent? In a shelter home, we, all the caregivers, they are also suffering from secondary trauma. So how to prevent that suicidal ideation from the children, and also how the caregiver can support them more effectively. To learn this, I'm here today. Thank you so much.
Thank you very much for sharing. So it's about, I want to make sure I'm understanding you correctly. So you're seeing suicidal ideation or expressed suicidal ideations from your children clients. And then also you want to prevent secondary trauma for your staff.
Because most of the time, if the caregivers, those who are the primary caregivers, are taking care of the children, and when they are always hearing that child is saying that, oh, I want to die, I will do something. So it's so scary for the caregivers also. So sometimes they are also getting very vulnerable and losing their confidence and asking that how we can help the child in a very, so that they can be also comfortable dealing with the children.
Awesome, thank you so much. Okay, I saw one more hand here. Yes, sir.
Okay, good afternoon, ladies and gentlemen. My name is John from Chatai Coalition, Cambodia. And what brings me today, because currently we are working with survivors from human trafficking as well as from the rape. And the survivor people, mostly they are adult, but our target group, rape victim, mostly under adults, meaning the children. So after they experience with the situation, they are facing with the trauma situation, and their mental was broken. So sometimes they feel that they are not important in the world. They want to go away from the world. They don't want to see anyone in the world. Suicide committees. So today is a good opportunity for me to learn how we develop effective activity to refuse or to help the survivor that have the feeling that they don't want to see anyone, they want to suicide. So I hope today we can learn a lot from the other people here that have the best experience on how to support the suicide dual people. Thank you.
Thank you, sir. So there are a lot of clients, you're seeing a lot of clients who are hopeless and feel like there's nothing else that they can do. Thank you so much for sharing some of your thoughts and experiences. So for those who may have not been able to share, some of you may be here because you have a profound experience of the impact of suicide. Maybe some of you here know someone who is suicidal or has committed the suicidal act. Maybe that's a friend, a neighbor, a family member. But since a lot of us here are maybe service providers who work for organizations, or donors, or just want to have general knowledge about suicide, so maybe you've heard stories directly from our clients, or maybe from our colleagues, or maybe stories from other people. So whatever your reason is, I'd like to invite and encourage everyone to approach this topic with an open mind and an open heart, and maybe also compassion towards ourselves and towards other people. So I understand that some of us may want to learn more. So being compassionate and kind towards ourselves may mean giving ourselves the opportunity to learn. That we don't have the perfect knowledge, we don't know everything yet, but we're here to increase that knowledge. And also for others to learn empathy towards our clients, but then also to the service providers who are providing these direct services to our clients. So let's dive right in. What is suicide? So particularly, I'm going to share with you about the suicide spectrum. So suicide, in a short sentence, is intentionally ending one's own life. It is common for people to think that it's a single event or a single outcome. But the truth is, suicide exists in a spectrum. It exists on a continuum with varying degree of severity and risk. By recognizing that there is a spectrum and that clients are experiencing suicide may be anywhere in this spectrum, we can better tailor prevention and intervention efforts, reduce stigma, and provide compassionate support to individuals experiencing suicidal thoughts or behaviors. The spectrum also underscores the complexity of suicide and the need for comprehensive approaches to suicide prevention, intervention, and general mental health care. So suicide, this is, I will try to share some of the terms within this spectrum. Please note that because it exists in a spectrum, it's not just like you belong in this category or you belong in this category. You can exist in several parts of this spectrum. So first is suicidal ideation. Okay, am I covering this slide or not really?
No, it's all right.
Okay.
We can see both ways.
Okay, awesome. So suicidal ideation refers to any thought about ending one's own life. Any thought. It can range from fleeting considerations of death or persistent thought about ending one's own life. So fleeting, very quick, it just came into my mind this morning when I woke up, or persistent. That may also be different from one individual to another. So others may, persistent may mean feeling or thinking about suicide the whole day. For others, that may mean once a day, every day, maybe for a week. For others, that may mean a few times a week, within a couple of months, or maybe a couple of years. For some, that may mean split. So maybe during the first quarter of the year-ish, some events have happened, they have some suicidal thoughts, and then the other half of the year is really good, spending time with families, a lot of protective factors. And then later on, there are a lot of triggering events. And so, again, it differs from one person to another. Suicidal ideations may also be passive. So these may include thoughts of, or wishes of, what if I weren't here anymore? What if I ceased to exist? I wish I woke up, I fell asleep, and don't wake up anymore. Or, it may also be active. Active, which means there is a clear plan for suicide. So the person with active suicidal thoughts start to have a plan on how to commit the suicidal act. So first, again, suicidal ideations, ideas, thoughts. From thoughts, we then move down the spectrum to behavior. So suicidal behavior are behaviors with some intent that may result in ending one's own life, whether fatal or not. There are actually a few points, that's a very brief statement, but there are a few points that I'd like to highlight there. So first is behavior with some intent. Okay, it doesn't have to be, I really want to die. It could just be, there's a part of me that wants to die. There's a small part of me that no longer wants to exist. Or it could be huge. I really want to die. Or it could be, I never want to exist again, ever. So it could be that, and then the second point I'd like to highlight is may result in ending one's own life. So it's not a guarantee. It may result in ending one's own life, whether fatal or not. So to be clear, I'd like to give some examples. This may include preparatory behaviors. So very common for some of our clients in the Philippines, giving stuff away to their loved ones. So especially for low-income population or clients, it doesn't necessarily have to be an inheritance. It just means whatever they have. The little savings that I'm hiding under the bed, or the cell phone that I've been saving for the past couple of months. It may also mean acquiring the means to kill oneself. So this may also differ from person to person, or culture to culture. So these may include, very common in the Philippines, rope or something to hang themselves with. Another commonly found, even for children, or actually also adults in shelters, they look for broken glass because it's accessible, because the properties where shelters were made are, during the construction process, there are a lot of materials that are left behind. So they try to dig through them. So you'll see like broken glass or a piece of nail or something that's rusty, so they know that it could lead to death. So those. Other preparatory behaviors also include saying goodbye to loved ones. Loved ones or people close to them. So these may include family members, but also for people who don't have support systems, or like family members or friends. This could also mean the service providers. This could also mean the staff. And saying goodbye could also be done in different ways. It could be saying, like, just in a passing statement when they're talking to someone, or when the survivors are talking to someone and they say, you know what, when I die, please know that I love you so much, that you've had a huge impact in my life. Very brief passing statement. It could also be a post via social media. Goodbye world. It could be like an angry post of, this world has done nothing good to me, like expressing all of these negative feelings. But it could also be just goodbye, thank you. Or it could also be the traditional method of writing letters. Whether they give that letter to a person or not, but they've prepared for it in case they die. Maybe if they'll find this in my deathbed, among many others. Okay, so suicidal ideation, behavior, and then further down the spectrum, we have suicide attempt. Suicide attempt occurs when an individual takes deliberate, self-injurious, non-fatal actions to end their own life. It's very important for this to be non-fatal because the suicide is not completed. It's an attempt. Okay? Okay. Seeing some heads? Okay, perfect. So attempts can vary in lethality and intent. Okay? Again, there's no single way to commit a suicide attempt. It could be a small slip or harm on the hands, so very common, or on the legs for others, so that it's not very easily seen. But it could also be direct, with very lethal methods. Common from our country in the Philippines that I've experienced with clients, drinking bleach, or there was a client who broke a piece of glass because the client could not find any means anywhere, so they broke a light bulb and used that light bulb and ate it. So there's also so different forms. Again, I'm giving examples right now, but I just like to go back to one of the first slides that I mentioned, that this is a very sensitive topic. And so again, please feel free to step out anytime if you need a little bit of air, or if you want to process some of these later, I'd be very happy to do that. But there's no need, it's not a showcase of being a coward or fear or in any way incapacity if we choose to step away for a moment, if we choose our own mental health. So, okay, I've provided some examples. Please note that suicide attempt could be done with actual intent. Okay, again, there's a part of me, whether that's a small part of me or a big part of me that wants to die, actual intent or inferred intent. Now, what do we mean by inferred intent? Inferred intent is an awareness that the act could lead to death. A client could deny all they want. You can ask a person repeatedly, was there any part of you that wanted to die? When you did the act, did you want to die? Did you want to kill yourself? And a person could say, no, I did not want to kill myself. There's no part of me that wanted to die. And so this is why it's important to probe further. What did you think would happen if you were to do this? So an example could be jumping in front of a fast-running vehicle, jumping in front of a train, or just jumping in front of a fast-moving vehicle in general. Now, if the client's answer, if the person's answer is different, like I think that I get injured. Okay, I'll share an example that's very common for our clients in the Philippines. It's common for them to find sharp objects to harm themselves. So some of them will say that when I harm myself, when I what's the right word for it? Slash myself. I think that it would cause a little bit of a wound, but that is okay. I think it would feel like with that burning sensation, but that's it. I feel like I'm going to have some marks on my hands. But if the client's answer were different and they said, when I would slash myself, I would bleed out and I might die. So the client is now aware that their act could lead to death. And so that act can be considered as a suicide attempt. Okay? Okay. So, just in case there's a little bit of confusion, let me just add this slide right here. Is it possible for a person to commit self-harm but not want to die? Okay, I'll just repeat that question. Is it possible for a person to commit self-harm but not want to die? Okay, since I will attempt to have an engaging conversation with the audience, so please know that this is a safe space. There are no judgment place, but I'd like to ask maybe some of your thoughts if that's okay. Does anyone here think that it's possible for a person to commit self-harm but not want to die? Yes, may I see some hands, please? Okay, awesome. Is there anyone here who thinks that whenever a person commits self-harm that they always want to die? None? None. Okay. We have a shared concept here from the audience. And the answer to that question is yes, absolutely. It's very possible for a person to engage in self-harming behavior without any intent to die. So if that happens, if there's no part of them, so as you can see it's highlighted, 100% for the reasons, other reasons other than to end one's life, this is called non-suicidal self-harm. Or for others, this is better known as non-suicidal self-injury. Meaning that the act was only meant to harm oneself, not to die. Okay? What are the reasons maybe for someone to want to harm themselves but not necessarily die? Why does this concept even exist? And so there are two general reasons listed on the screen. The first is internal. It could be to escape pain. So for survivors, this may mean escaping from physical pain, like in general, having physical health conditions that cause them to have physical illness, just in general. But also it may mean physical like injury or the impact on their bodies from their experience of abuse or exploitation. So it's possible to, some common examples would be, especially for those who have experienced some form of physical violence when they were trafficked or exploited. This includes pain in whatever part of their body they were injured. Face, belly, sometimes their private or their sex organs. But for others, it's maybe psychosomatic. So because of the emotional impact of their abuse, they experience this physical symptoms. These include migraine or constant headaches, or sometimes like that uneasy feeling in the stomach that never seems to go away. Like it's like feeling nervous for no particular reason, or it could be triggered, could not be triggered. So different ways. So some people or individuals in general, but also including clients or survivors, there may be a desire to escape from this pain. It feels painful all over my body. I don't understand my body. By hurting myself in this one particular part, the pain is focused in this area. And this pain, although it's painful, although it hurts, it's less compared to what I feel everywhere else in my body. It could also mean, so that's similar to also feeling better, but feeling better also means, aside from the physical pain, it's also an escape from emotional or psychological pain. I keep thinking about how, well, all of these reasons, that because of their experience of exploitation and abuse, they are hurt emotionally. And they don't want to, survivors or clients don't want to continue feeling that way. And so survivors or clients cause pain in one's body to feel better. It may also be a form of stress relief. So again, psychosomatic feeling, like all of these, having a lot of worries, anxiety, depressive thoughts, intrusive thoughts. So this is an escape, stress relief. Another one that I wasn't able to include in the slide, but it's also common that we found in clients, is to feel something. So these are escaping from all of these feelings, but a common one is also to feel something. I have some clients in the Philippines who said, "Miss, I cannot feel anything. I don't feel joy. I don't feel anger, even towards my perpetrator, towards myself. I don't feel excited or happy. I just exist. And I want to feel something." And so the individuals cause harm towards oneself. So internal, but it could also be external. So external could be, which means wanting something from the outside, right? So this could mean gaining attention. Usually, if I'm maybe my good self, or just I'm my normal self, not even good, just my normal self, no one really pays me any attention. It could mean in the family context. So my mom cares more about my younger siblings or my older siblings because this and that. But it could also mean for some of our clients, like those living in the shelters, because there are limited number of service providers and a lot of clients. Oh, okay, they're giving attention to all of those other clients. Maybe if I harm myself, then the attention would go to me to get that attention or sympathy. It could also mean getting something to happen. So this may also be like a controlling behavior. So sometimes it works in like relationship. So maybe if I hurt myself, then my partner won't leave me because my partner knows that I'm not in a good place right now. So whatever that reason is, again, we're not trying to justify all of these reasons. We're just trying to understand what self-harm is. In this case, non-suicidal self-harm. So on the other end, we have suicide attempt or suicidal self-harm. Okay, so suicide attempt is a potentially self-injurious act committed with at least, again, some wish to die as a result of the act. some wish to die. There's a part of them that wants to die. Therefore, behavior was in part thought of as a method to kill one's self. To be clear, intent does not have to be 100%. Okay? Okay. Okay, some of you may have some questions here. I'd love to answer them towards the end, but basically that is our spectrum, the suicide spectrum. And again, it's very important to understand this because by understanding where our clients are, where the survivors are, what their risk levels are, we're now able to better tailor our intervention efforts specific to their individual needs. I'll talk about that in a bit, but in general, why is it important to talk about suicide? So for clients, service providers, and in general for the anti-trafficking community. So survivors are at high risk for mental health disorders, the spectrum of mental health disorders. These include depression, anxiety, PTSD, or symptoms of these mental health disorders. Some of these, survivors are at risk because of the experience of abuse and exploitation from the perpetrators. Or in general, people with complex health challenges this has a compounding impact on one's mental health. In general, clients are at risk for mental health disorders. First point. Second point, if survivors are at risk for mental health disorders, these are then major risk factors for suicidal ideation, attempts, and suicide death. In fact, research shows that there are high rates of suicidal ideation and behavior among survivors. I'll share the research in the next slide. So considering these needs, what are the available resources? And the truth is, there is lack of mental health professionals. For us in the Philippines, but I think also here in Southeast Asia and globally, there's just a general lack of mental health professionals. If I may share a little bit in the Philippines, just for context, we had our psychology board, so that act for the psychology board gives the outline for who can be registered as psychologist or psychometrician. So the act was passed in 2009, but it wasn't until in 2014 when the board exam started or when previous practitioners were recognized. So from 2014 to 2023, there are only 1,700, I think a little bit more, psychologists in the Philippines. From this number, there are only around, as of 2023, 800 practicing psychologists. From the 800, this means from the general population, considering the population of the Philippines, this means there is one psychologist for 125,000 Filipinos.
Oh.
That's for Filipinos in general. That's not even specific to survivors. There's a general lack of mental health professionals. These includes counselors, social workers, psychiatrists. And this is just in the Philippines. And I know those from different countries and cultures experience the same thing, just a different number. Apart from this, if there are available resources for mental health professionals, or there's mental health care available, there's very low utilization rates. Why? Because of stigma about mental health care. In the Philippines, there's a word that we commonly use, quote unquote, it's called buang. That means crazy. So it's very common for Filipinos to think that once a person seeks mental health support, when they talk to a mental health service provider, that they're buang, that there is something wrong with them. It doesn't, the people don't have to know what the story is, what the background is. But the fact is, this person met with a mental health professional, so you must be buang. You must be crazy. And people don't want that. I don't want to be labeled as buang. I don't want to be labeled as crazy. I don't want people to look at me as I walk across the hall and think that there's something wrong with me. So I'd rather keep this to myself and not seek any mental health support. Or, also very common, just to share, Philippines is a largely Catholic country. And so it's very common in the Philippines for service providers to say, not for service providers, I'm sorry, for others in general, especially the adults, to say, just pray for it. You're experiencing suicidal thoughts, talk to God. You lack prayer. And so the clients, they already know what's going to happen. And so the clients are like, I'd rather just stay in my room. I'd rather just keep this to myself. No one would listen to me anything. Or no one would give me a helpful answer solution anyway. And last point, there's a lack of culturally adapted evidence-based intervention. So there are already available resources for suicide prevention and intervention, but there aren't a lot that's available in particular cultural contexts, and we know that's different from culture to culture. I'll share a little bit more in the next slide. Next slide, sorry. So this is just to share some of the research that I mentioned earlier. So in 2014, there was a study in the US that 41.5% of women attempted suicide while they were trafficked. And there's a 20.5% of women who attempted suicide after escaping. Also in the US, there was a study that 75% of homeless youth who had experienced sex trafficking reported suicidal thoughts, and 84% of these youth reported a suicide attempt. Now I know there are a lot of Southeast Asians here, hello, neighbors. So also presenting a Southeast Asian study in 2015, 5.2% of survivors, this is a study for countries in the Mekong area. So we will share the names of the researchers later on. 5.2, and also in the web, so you can check them out yourselves. 5.2% of survivors enrolled in services had attempted suicide in the past month when the study was conducted. From this number, 4.2% are men, 6.3% are women, and 5.5% are children. And I think this correlates with what has been shared earlier, that the stakeholders or the clients served are children, women, men. So from the clients or service providers, why then is it important to talk about suicide for anti-trafficking staff? In a study in 2022 by Dr. Curtis Kotsai, again we'll share the resources later on, their study was on practitioner experiences responding to suicide risk for survivors of human trafficking in the Philippines. It has been found that stress, anxiety, and there's a lot of stress, anxiety, and emotional burden for anti-trafficking staff. This is one of the quotes from the research. The staff mentioned, "I feel uncomfortable because I fear that the client would die. It's as if I have not done anything to help if they would die. I would say, oh my God, I hope none of my clients are suicidal. I'm really shaken. I mean, it's a life. I bring home the worry." So in general, for service providers, there's a lot of emotional burden. Service providers are also humans. Clients are humans, but also service providers. We experience significant stress and emotional burden. This, to be clear, this doesn't mean that service providers are not equipped, are not capable. are not emotionally resilient, or not at a place where they can provide services. Regardless, it's still talking to clients with suicidal thoughts or ideation places a burden on the providers. There's a pervasive sense of responsibility, worry, fear, and self-blame. It doesn't mean that the service provider has done something wrong, but there's a worry that could I have, after that session, have I done anything to cause that client to have suicidal thoughts? Or did I push the client to have from thoughts to act on their thoughts? And lack of training, so that's general burden, but it adds if the staff or service providers are not trained, not equipped to provide these services. Next point, there's a positive staff, most often, if not all, come from a place of wanting to help, wanting to provide support, wanting to care, wanting to provide services to clients. There's a desire, an intent to help. However, it's still possible to cause harm. Again, stigmatized attitude and lack of clarity regarding the risk assessment could cause it. So again, the example I mentioned earlier of saying just pray to God. You can do this, pray to God. Okay. Or another common example that I've heard is just go out to the nature. Look at the trees, or take some breathing exercises. Now, as service providers, we may know that those steps are helpful. But it's important to recognize that it may not always work for every client. It may work for some, but not for everyone. And so staff or service providers may respond in unhelpful or harmful ways. So instead of the client feeling that, oh, okay, I have a safe space where I can share these thoughts, I can finally talk about it. Knowing that service providers respond a certain way, survivors would rather keep it to themselves. Survivors would rather say, it's better not to say anything, at least I'm not judged. At least I'm not given an idea to do something that's not aligned with what's realistic for me to do. And lack of referral options. So service providers may want to, it's important to assess as service providers, where are we in terms of the ability to provide these services and intervention to clients. We want to help, but we also, aside from just providing care, we want to provide quality care. Care that's actually helpful for the clients. And so if we're not at a place where we can provide quality care, sometimes the best option would be for us to refer the clients to more experienced mental health professionals. However, again, as I mentioned earlier, there's just lack of accessible options. Aside from this, staff from the research also mentioned that there's a preference for the client to be like discharged or referred, because there's that worry of, okay, the client is still assigned to me. If at any point during this time they act on their suicidal thoughts, the responsibility feels like it's on me. There's a want to, okay, it's yours now, your responsibility now. And in general, staff may also have trust issues with unknown service providers. I want to refer this person to a psychologist, but have I worked with a psychologist or psychiatrist before? Do I know that they provide trauma-informed care? They may be psychologists, they may have like, all of these like counseling methods, but do they know how to talk to survivors? Are these psychologists aware of the trauma that the client has experienced? So just some questions to ask. And so in general, there's a critical gap in knowledge. There's a lack of intervention that have been tested with survivors. And there is a need for culturally competent, evidence-based care in low-resource setting. Why low-resource? Again, because we want the services to be accessible. There's an urgent need for capacity building. This means that direct service providers have repeatedly expressed the need for training and support. Again, the desire is there, the want is there. I want to support, I want to be helpful to the clients, to our organizations, but I need training, I'm not equipped. And aside from this, especially when one is working with an organization, may be helpful, or there's a need for a clear organizational system. What happens when the client gets into the system? What is the process for monitoring and follow-up? Where is the accountability? How do we make sure that, for instance, if I'm providing this service to a client and then just for some reason, say as a service provider, I'm on break, right? Or have a personal matter that I need to attend to make sure that the client is not left behind, that they continue to receive care even if you're not around. So for the organization to work together to provide those services to the client. And so those are some of the issues that we found, our discussion about what suicide is and why it's important to talk about suicide. So now I'd like to share with you what has worked for us at Liaison. What are the efforts, suicide prevention and intervention efforts that we found are actually helpful. So at Liaison, we try to keep it as simple as possible because we found that that's actually helpful for clients. It's easier for them to remember, but also it's easier to train staff. It's easier to remember. So we have a lot of acronyms. So for this particular crisis intervention method, we are using AIM. Very simple. A means assessment. We are trying to assess the person's suicide risk level because again, only when we know their assessment, risk assessment, do we know the specific intervention that we can use. From assessment, we provide tailored intervention. And it's not just a one-time thing. Not because we've already provided intervention for you means that's it. So it's also very important to have monitoring. So how does this look like? I'll show briefly some of these with you. So for the A part, assessment, we are utilizing the Columbia Suicide Severity Rating Scale, or what we call the CSSRS. Sorry, not what we call, that's what it's known for, CSSRS. So among all of the screening tools available, why are we using this? Because it is a tool that has simple, plain language questions that anyone can ask. You don't have to be like a certified mental health professional. You don't have to have a license. You can just, as staff, could ask this question. In fact, this tool is used in hospital settings, guidance and counseling settings in schools, because it's easy. Easy for the staff to ask, easy for the clients to use, to understand. And this particular tool, as you can see, there are already like colors, that automatically helps the staff to look into the assessment. What is the risk assessment of this client? Just by simply looking at the tool. There are 6 questions. I'll share it into the next slide. So very easy, appropriate for low resource context. You don't have to print out a lot of materials or bond papers or carry around our gadgets. 6 questions. What are these questions? So there are actually different variations of the tool. So depending if it's an initial assessment, if it's a reassessment. So first is we have question number 1. Have you wished you were dead or wish you could go to sleep and not wake up? Have you actually had any thoughts about killing yourself? So if we go back to the suicide spectrum, these are suicidal thoughts. So yellow, low risk. If the client has answered yes to step 2, we proceed to ask step 3 to 4. Have you been thinking about how you might do this? There's an increased risk because the client has now identified a method. There's a method used. 4 and 5. 4 is, do you have intent? 5, we're looking at a plan. So from the thought, is there now a plan on how to commit suicide? And towards the end, step 6, have you done anything, started to do anything, or prepared to do anything to end your life? This refers to suicidal behaviors. Because again, as we've identified earlier from the suicide spectrum, a client can deny all they want that they're experiencing suicide. A part of them wants to die. But if they say, if they're doing something which has an inferred, or which they know could lead to suicide, it's considered a suicidal behavior, and we consider that as high risk. Well, again, this is one of the tools, so lifetime, but if in the past 3 months that risk is higher, so it's high risk. Again, brief overview, we'd love to share more of this with you later on. And so from A, assessment, we now proceed to intervention, I in AIM. So we are utilizing Stanley Brown Suicide Safety Planning Intervention, or what we call the SPI. This was developed by Barbara Stanley and Gregory Brown. We are using this method because it's brief, collaborative, and evidence-based. So there's already research that backs it up. It's collaborative, which makes us look into what works for survivors, highlighting or centering their voices, knowing that survivors know which coping mechanisms, which tools are actually helpful for them. We can suggest, again, all of these things, let them know, take a breathing exercise, meet with a psychologist, but the survivor knows that are actually accessible for individual situations. So what are the parts of the SPI? First is the narrative interview. Narrative interview just means asking the client, asking the survivor what happened during your most recent experience of suicide. Whether that's a suicidal thought, whether that leads to a suicidal act, we're just trying to understand what happened. By using the client's experiences, we're able to show the survivors about their own story. We can paint this picture for the survivors and hopefully show what are or identify the warning signs for survivors to see, oh, okay, this was a triggering event for me. What did I think? What did I feel before having that suicidal thought? And maybe when I had that suicidal thought or act, what led to the escalating the risk? From the narrative interview, let's spark that a little bit. The second part is conducting psychoeducation. These are actually related. So from the narrative interview of the client, we then plot their story in this curve. This is what we call the suicide risk curve. So as you can see, it showcases, there should be an arrow, time, and then this is risk, which basically shows that with time, the suicidal thoughts decrease. So it gives clients and survivors the idea that it's not permanent. Suicidal thoughts come and go. There's an end to this thought. Now, does this mean that I can never have suicidal thoughts again? Not necessarily. I can have another episode, but that they will eventually go away. And so knowing that, and by understanding the patterns, we could then see what are my warning signs? So it becomes preventative in the sense that the client does not have to wait for them to have suicidal thoughts or suicidal act before the clients do something. And just in case, for some reason, it does lead into a suicidal thought, what can I do to decrease the thought? Or what can I do for the thought to not escalate into an act? So after this, we now go to safety planning. Also very simple. This is just a one-pager. We discuss, and again, it's a collaborative method. So we discuss this with a client, 6 steps. Basically, first is knowing the warning signs. What are the thoughts, actions, behaviors did you notice when you had the suicidal act? And this is actually, well, not the easiest, right? But because we have the narrative interview from earlier, we can now help the client identify what happened during their most recent experience of suicide. From that, step 2, we're looking into internal coping strategies. Before the client can ask support, what can they do on their own? Creating a sense of independence, but also accessing resources that are available to the clients in that moment. Next, we have social contacts and distractions. So this could be places, this could be talking to a friend, someone who's really funny, talking to a child. It doesn't mean sharing one story, but just a form of distraction. So they're not focused on the suicidal thought. And again, waiting for the thought to pass. Next is this time talking to family members and friends. So this is when, are there people or support people that I can talk to and share about my thoughts? This person does not need to have the answers. The person does not need to tell me or give me advice on what to do. Just a person that we can share these thoughts to. And then step 5, professional support. So this is where service providers can come in, counselor, therapists, social workers. And last but not least, but very important steps, what can a person do to reduce access to the means? So by asking the narrative interview, hopefully the client is now able to share what method they have identified. So say if it's a piece of glass, we can then ask the client, how do you have this piece of glass? Where are you keeping it? Who can you give this piece of glass to so that you don't have access to it anymore? Just in general, keeping the environment safe. So brief overview, again, 6 steps, but it doesn't have to be done step by step. The client can skip. Very intense thoughts. I don't think I can do my own internal coping strategies, and so I'm going to talk to the professional. And then last in our aim, monitoring. This is our process at Liaison is consistent with the Suicide Safer Care Pathway, which outlines standards for continued monitoring, ongoing safety planning, ongoing reassessment, and frequency of contact. It's intended to support shared decision-making between survivors and clients while promoting best practices during high-risk periods. So depending on the risk assessment of the client, the follow-up also varies. So of course, those with higher risk, the frequency of the follow-up is also closer. Those with lower risk are also less, until eventually they exit the pathway. Now, for example, they already exited the pathway, they again have, the survivors have some suicidal thoughts, then we just go through the aging process once again. And so I think that's it. That's it. This is actually just like the presentation, the keynotes earlier. This can be a topic for several days because there are a lot of steps in the AIM process. So at the Liaison, we want to share all of these information to other service providers who may want to provide the same care and services. So we actually have a capacity building program where we discuss all of those things that I shared with you earlier, but just more specific. And through this program, we can provide specific support to what may work for organizations. Again, because that is based on different cultural context and situations, number of staff, background of the staff, etc. So try to pack that in one session. That's it. Thank you very much. I'm not sure I don't think we have time for do we have time for questions? Right, that's it. Oh, 10 minutes for 1 minute. Okay, 1 minute for questions. Does anyone want to ask a question? Yes, sir.
Hi, that was great, but my question is, the rate for re-trafficking for victims to survive and escape is quite significant. What role does these programs and therapy play in preventing that?
Very good question. Again, this whole process, the prevention and intervention efforts, plays a huge role in the whole thing. So from the time that, it depends on the organization. If the organization is currently working with clients who have just been rescued from the perpetrators, this could be utilized. If the clients are already in the transitional phase, or maybe in the transitional homes, or even in the aftercare, it could also be utilized. It's not only specific to a certain organization or people with specific backgrounds. It could be utilized anywhere and anytime. Thank you very much. Okay, time's up. Thank you, everyone. Okay. If you have questions, you can come on the side.
Yeah, we asked something just from you.
Okay.
Yeah. So we have a problem in our town of middle-sized towns, like Thailand is a lot. There's a wave of suicides going on right now. Like this year, only from one bridge, 40 people jumped already to the river. Okay, so we're thinking so what do we do? we're like a part of a church here.
Okay.
So what could we do? And we were thinking, could we maybe ask somebody if we could like put a sign on and work together with the government officials too? Like there would be a number you could call. What do you recommend? What could we do like to prevent something like this? And they asked us to go to schools as well, to like because they're mostly young people who are committing suicide. So how could we like actually talk about these in the schools or something?
That's a really good question. I think it's also specific to like the population that we're trying to serve. So in this case, you mentioned yes. So like, what is the background maybe of the town, etc. So for instance, specifically our work, we work specifically with survivors. So we have all of these backgrounds, but it's important for us to hear from the survivors themselves about what are their specific triggers. What are so we talk to our survivor leadership council and ask what are the common trends that you see. What do you think might be helpful? What do you think are not actually helpful? So from those information, so it's like a holistic approach. So we're looking into the help of the professionals, but then also those who have experienced themselves. So I don't know if you have access to talking to those who have been, to those who committed suicide, yes.
So we have financial problems. There's also like young people who maybe broke up a relationship and they're drawn that they don't jump. And they might even find somebody, a partner, to go and jump together if they don't.
Afraid to go
alone. They find a friend online, they go and jump together.
Okay.
Different reasons, very different reasons, also different ages too.
Yeah. Is there a way for you to like reach out to these people? I'm not sure if that's accessible.
That's what we were thinking. Like, would it be a good idea if we had a sign on the bridge? Like, hey, if you feel like you're not feeling well, or need somebody to support you, like please call this number, and there would be somebody to always answer that
Before
line.
we jump, we want to buy find meal.
Yeah.
I don't know.
Come to have dinner with us before.
I think because it's a general approach, there's a bridge, right? And they recommend the act there. It might be tricky, so I don't really have like a specific answer. But what worked for us is we constantly ask when we talk to the clients, we don't actually know if they're suicidal or not when they reach out to us. So what we do is just continually share the message, like all throughout. If you ever have any, if you want to share anything, you may reach out to us. But also that, and then it just like networks, so people are more informed about it. But we also try in like bigger settings. We kind of have like these bigger engagements, and then we talk to the people about it. So people with suicidal thoughts are not. It's a misconception. I think people are used to like thinking that these people could just like talk to anyone right away. But the truth is that it's a process for everyone. Those with suicidal thoughts may not know what they can do. What are services accessible, or the service may even be accessible, but they may not want to avail that service. So we have a lot of clients that we've reached out to because they've already explicitly mentioned that they're suicidal, but they're either just not ready, and so we just try to see or like monitor for other people, like do they have support people, can we talk to that support person instead and look after them. So with this, it's general with like a location, so I think there are a lot of factors like also to look into. Sorry, I don't have a specific answer.
But this is very helpful as well.
Yeah, it's good to know like some of the methods are kind of like, like you said, you don't have to be like a psychologist yourself or any professional.
That's also helpful because we also lack
we have the same problem.
mental health workers. We lack
therapists, everything.
Yeah, that's really awesome. We found that same problem, and so we thought, what could we utilize for our staff who may not be like, or those who are like in the grassroots community who don't really have a lot of background education and training. What could we do to